Dear friends and colleagues, it's 6 p.m. in Paris, 6 p.m. in Lille, 7 p.m. in Athens and Ankara, 12 p.m. noon in New York. And it is my great pleasure to welcome you all to this special ICH webinar dedicated to the highlights of the recent International Myeloma Society, IMS, annual meeting, which took place actually last week in Toronto. As you know, this IMS meeting has become one of the most important global platforms for presenting cutting-edge science, practice-changing data, and innovative approaches in the field of multiple myeloma. This year's edition in Toronto was no exception, bringing together leading experts, clinician researchers, and patient advocates from around the world to share knowledge and set the tone, actually, for the future of myeloma care. And believe it or not, the future of myeloma care is about cure. Cure was the key word in every single session I have attended. So during today's webinar, brought to you by the International Academy for Clinical Hematology, we will revisit the most impactful presentations and discussions from IMS 2025, covering topics ranging from early intervention strategies, especially high-risk smoldering multiple myeloma, high-risk multiple myeloma, the evolving role of quadruplet regimens, bispecific antibodies, other immunotherapies, CAR T cells, but also antibody-drug conjugates, smaller molecules, all of these agents that are reshaping the treatment landscape. We will also reflect on key debates. The concluding session of this IMS meeting was a fantastic debate on what to choose in the early relapse setting between bispecific CAR T cells or antibody-drug conjugates. And of course, we do have all the real-world considerations, and we would like to debate with the panelists tonight how these findings may influence the day-to-day practice. We're very fortunate here at the ICH to have with us an outstanding panel of experts who attended the meeting and who will guide us through the key data. They will give their interpretation of their clinical relevance and share the personal perspectives on how this knowledge can be translated into improved patient care. On behalf of the ICH, I'd like to thank you warmly for joining us. And of course, this is a live broadcast. I invite you to actively participate in the discussion with your questions and comments. Let's begin our journey with our colleagues, Dr. Susan Lynch, Dr. Meral Beksak, Dr. Thierry Facon, and last but not least, Dr. Dimopoulos. We may have a couple of other colleagues who will join during the discussion. So thank you all for joining. And before going into very detailed discussion, I would like to ask each of you about his best of IMS. Just very briefly, what did you like? Beside, of course, the convenience of the convention center, the hotel nearby, but also the incredible awards ceremony we had. What is the best of science of IMS? Who would like to start? Shall I do ladies first, or ladies first? Thierry agrees. Susan, okay.
Maybe I go ahead.
Dr. Baylis has just joined us. Nizar, welcome.
Nizar. I was really excited about novel approaches in CAR T cells. So Dr. Malangrodi did very impressive research on the tandem CAR T cells giving BCMA and GPRC5D. Dr. Saad Usmani presented the data. It's a small clinical trial, and they're in the dose finding, but they didn't have any major safety signals. So overall response rate was really excellent. It's a little bit the question, if we move CAR T cells up front, and we have high response rates, do we need overlapping toxicity by adding a GPRC5D CAR T cell to increase the response rate, overall response rate from 90 to 95%. So that was a question, but I found the research extremely interesting. Other highlights were, for instance, Majestic 5, so Tec-Dara Revlimid for newly diagnosed patients. The German myeloma group presented data, also very exciting with 100% response rate. So altogether, I found most interesting the data moving immunotherapy more upfront and potentially replacing transplant.
Excellent. Thank you very much, Susan. Meral, any thoughts on your side?
Well, I think it was so broad. It's hard to just simplify. I agree with Susan that I was also impressed with the double CAR T treatment approach. And also there are several biomarkers now associated with CAR T and immunotherapy toxicity, which I find very practical, looking at the ALC values, ferritin values, and so predicting neurotoxicity and CRS and other side effects. This could be very convenient to use in the daily practice, but this is one end, so very convenient for daily practice. But on the other hand, the basic science was really amazing. The precursor states, looking deeply from Spain and from Mauro's group and also from Boston, they were really digging into the precursor B cell and plasma cell, both at the immunophenotype and also genotype level, and to predict which patients are going to move towards myeloma. And so the discussion, I think, will be one of our topics today, how to approach smoldering multiple myeloma. So there are many things that I'm impressed about. So it's wonderful to be at a meeting which is focused on a topic, and I prefer to have one oral abstract session, because you are diverted between two oral sessions. Otherwise, it is great to freshen up your knowledge and get insight for future.
Wonderful. I'm glad you're introducing the smoldering and the precursor diseases, because obviously that's going to be my first chapter in the discussion. But let me move now to Thanos. I thought you wanted to jump in.
Yeah, well, I think, there was no a single, breakthrough presentation, a new molecule or something. There were advances in the management and the application of bispecifics, the CAR T cells, CAR maintenance after bispecifics, the role of cell modes in combination. I think we have reached a level where, we have CAR T cells, bispecifics, antibody drug conjugates. I feel that we need maybe new molecules with a different mechanism of action. I haven't heard anything about vaccines in myeloma, so I believe that this is an area where things are not moving, so well. And, basic science was interesting about mechanism of resistance to several therapies. But to be honest, there was no something, completely new that unexpected that was presented there. It was a very nice meeting, very well organized, and there were some real life practice attitudes that probably will help many practicing physicians in the application of these new drugs and molecules.
Thank you, Thanos. Indeed, it was really a very strong consolidation meeting. We didn't see the release of new results or reading of new trial results, but obviously we needed this consolidation and to see the impact of all the studies we discussed over the last couple of years. Nizar, you were a member of the local committee. You were our local host, and among, of course, the other Canadian colleagues. And thank you again for putting together a wonderful event from a scientific, but also a social perspective. So I know you did also the best of IMS at the end. So I'm asking you now about one coup de cœur.
Thank you, Mohammed, and thank you all for attending the meeting in Toronto. It was a pleasure to host all of you. As you said, I gave the best translational medicine at the presentation at the end of the meeting, and really was a challenging task because there was an enormous number of presentations that were very impactful. As Thanos and Suzanne and Miral said, the advancement in the understanding of the biology of the myeloma is incredible. I was struck with one of the abstract. I may say two of them, perhaps if you allow me. One of them about the toxicity presented by Adam Cohen, understanding the mechanism of enterocolitis and some of the neurological toxicity, especially the delayed neurological toxicity we see in multiple myeloma patients with CAR T cells. And some of the correlative studies they've done, they showed clearly is driven by CD4 CAR T cell population. Which is interesting. And they demonstrate by biopsy of the tissue in the colon, but also the CSF that was dramatically enriched for CD4 cell population. We need to do further understanding of the phenotyping of these cells. They really have some unique phenotype or something unusual of some mutation, and then perhaps that allow them to cause these side effects. And whether they are clonal or not, is it driven by TCR or simply by the CAR T? But nevertheless, the first step toward a better understanding of the mechanism that leads to these delayed neurotoxicity and enterocolitis, and proven by biopsy of the tissues as well. The other interesting abstract I thought was an abstract by Larry Boyce from the Emory University, where he did an assay in vitro to understand how myeloma cells escape the killing of CAR T cell. And this is a very cool assay where he was able to monitor continuous imaging of the interaction of the T cells with the myeloma cells. And he will monitor over time, and cells that survive beyond the initial 4 or 5 hours, he's able to zap them with a laser to allow them to fluoresce and then sort these cells. And interestingly, he did a transcriptional analysis of these myeloma cells, and he found some unique signature driven mostly by loss of the ER stress response, or the unfolded protein stress response, which sounds counterintuitive, but this appears to be driving these cells to be resistant, as well as loss of some of the cell death gene, apoptosis genes. And why was this abstract caught my attention? Because Dr. Holly Lee from our group, actually at ASH last year, presented a work where she studied the resistance of myeloma cells in vitro to bispecific antibodies. And she drove this resistance over several months, and eventually she made these cells resistant. And the transcriptional signature she identified was exactly the same signature that Dr. Boyce independently found in his T-cell resistant myeloma cells. So I thought we're getting some insight now about beyond antigen loss, what are the intrinsic mechanism that lead to resistance to immunotherapy.
Excellent. And we'll come back to your first choice about the toxicities, because we will discuss the different options, but I will drive the debate from a toxicity perspective, because when your median PFS is roughly in all trials around 35 or 36 months, then the question is more about toxicity and tolerance and feasibility. Thierry, last but not least, your coup de cœur. And Thierry attended a lot of the sessions, he is extremely disciplined, he was.
Yes, yes, that's true. Nevertheless, I will not select any special abstract. I think I would like to go back to two things. The first, you mentioned the first in your introduction. The term cure has been mentioned several times, more than in the past, which we can understand. And the second point is that it's an impression, basically. My impression is that we have closed one part of myeloma therapy history, and basically this year 2025 is you have before and after. Basically, what we have done in the past 25 years is to combine PIs, IMiDs, and CD38, and what has been shown, not for the first time, but going back to the Perseus study, for example, the similar studies in the elderly, Perseus will probably have median PFS, let's say 17 years. This has been said by Philippe and Peter Sonnefeld, and that could be PFS could be around 90 months, 100 months in the elderly, and so that's one part. So this is a kind of reset of the myeloma therapy landscape. We have this, so you can achieve with CD38 VRD and transplant, you can achieve this in not in all patients, but At least the median is more than 15 years. And then you have all these, what we have said, all these bispecific antibodies, CAR T-cell therapy, and this will basically open a new part of the of myeloma therapy. And my impression is that we know a little bit more than in the past what we have done. We have basically more follow-up. So we got recently the CARTITUDE-1 long-term study results, for example, which are quite impressive study results anyway. And we know a little bit more about resistance. We know a little bit more about toxicities, etc. I agree with Suzanne that the Majestic 5 is really impressive because it's just able to figure out what we may get in the future with bispecific, and at this time we have already trispecific in under development. So my impression is that we have closed one part of the story, and starting from now, we will have to implement basically all these new drugs, all these new modalities, and that will be, and this is at the end, this is good news for patients.
Excellent. Thank you, Thierry, for setting the stage. So now let's dig deeper a little bit, and I'll be more specific, and we'll open the first chapter, which has been discussed a lot during this IMS Toronto meeting, mainly whether we or we should not treat smoldering multiple myeloma. And just as a background, as we all know, and to our audience, this has been a matter of debate now since many years. We've seen data from Spain with long-term follow-up using just IMiDs. We've seen the GEM-CESAR trial, full total therapy for smoldering multiple myeloma, including triplet induction and transplant. We've seen the lenalidomide data from Sagar Lonial and the ECOG, and more recently, we've seen the publication of the randomized phase 3 trial, Aquila trial, in the New England Journal of Medicine. First author, Professor Dimopoulos here with us, last author, Rajkumar, and many distinguished colleagues in between. So we have a phase 3 trial, randomized, state-of-the-art, with, despite all the criticism, one would say, clearly showing that treating is likely better than placebo. Now, what is the next step? What is your approach? And here, what I'm asking for is not a sort of a clinical research debate, whether you like or don't like the trial. I think our audience would like to hear from the expert like yourself, what should we do tomorrow morning with the next high-risk smoldering multiple myeloma coming into our clinic? Thanos, you would like to jump in?
Yeah, I can start. First of all, we have to, to clarify that what we call high-risk smoldering myeloma today has a probability of 2-year progression about 50%. So I think the most important issue for me and for my patients is to assure that they have a close follow-up. By, I mean, it is more important in my mind if you have a patient who has high-risk smoldering myeloma to reassure him that by a close follow-up, yearly bone low-dose CT, close follow-up of monoclonal protein, paying attention in small changes in hemoglobin, that you will be able to catch the evolution before he develops any event, rather than automatically saying, you need treatment. I think this is something that it's still individualized, and I'm not among those who say that all patients with high-risk smoldering myeloma defined by the criteria that we have today, the 2220, should be treated. This is something that should be discussed. I think it's important to have a treatment that will be approved, but clearly it depends on several factors, primarily from the patient's point of view. What I think is not acceptable today is to have a patient with smoldering myeloma coming with a fracture or with renal failure or with significant anemia.
Thank you, Thanos. And such recommendation coming from you, who contributed a lot into this trial, is extremely important. I'm sure the audience will remember this. Susan.
For me, it's important to point out that Thanos was talking all the time about high-risk smoldering multiple myeloma. But in the Aquila trial, all smoldering myelomas were included. The inclusion factors said, 11% plasma cells and a free light chain ratio of 8, or 11 plasma cells and suppressed suppressed immunoglobulins. So, and I think that's for me a little bit a message I want to spread. Do not treat all smoldering multiple myeloma.
Absolutely.
I think it's important that we make that differentiation. I'm not sure whether Janssen might go for approval for all types of smoldering myeloma, as patients were approved in the clinical, or patients were treated in the clinical trial. So how do we do that? You ask me, how do we handle this? If somebody is young, has smoldering multiple myeloma, and I see it's progressing, usually I treat those patients.
Yeah.
But then I treat them like multiple myeloma, I have to say. Then I don't want to treat patients with DARA and then create maybe resistance, and the patient is okay for 2 years and then becomes resistant to CD38. And once there's active multiple myeloma, I have a problem. That's a little bit, the issue what I have. I think we need more data. Should we go full speed ahead with high-risk smoldering multiple myeloma, or should we treat a little bit with DARA only? I don't know how you do this.
So my role as a moderator is to be fair. So yesterday, Vincent Rajkumar sent a series of tweets explaining his opinion about this, and he is, of course, clearly highlighting that there is no induction of resistance, and we have the proof from the lenalidomide studies done in the past. So there's no suggestion that such resistance is clearly proven. But your point is well taken. Also, among the arguments of Vincent in his tweets was that the idea, although we feel comfortable maybe with it, to give a full myeloma therapy, not a single agent, is not proven or confirmed. It's just a feeling. But again, your approach is absolutely.
Mohammed, if I can just make a point, I think the dynamic models that take into account small signs or symptoms of evolution of the disease are much more important than a static model 2220, which of course is necessary when we conduct a trial, because when you conduct a trial, you have inclusion criteria and exclusion at a certain point. But in real life, I think it is more important, to, stay back. You see a patient with smoldering myeloma, check him again in 3 months, see what happens, see what is his expectation, see what is his age. I have an 87-year-old patient that, fulfilled, high-risk smoldering myeloma. I gave him daratumumab because, I told him, if we delay the progression for 3 years, you will die of something else. So it is completely different. And I think that Vincent is a very strong proponent because he believes that there should be a treatment approved by FDA, which I think it's correct based on the study. But in real life, smoldering myeloma represents 0.5% of the total population. So this is a huge number, 0.5% prevalence.
Thank you, Thanos, for these clarifications. Miral, what is your opinion?
Well, I think I also tempted Vincent Rajkumar by my tweets, saying that I'm not very happy with giving a monotherapy to high-risk smoldering myeloma, and he posted that long series of posts. in my own experience, we were participants of the Aqualia trial, and I can give you an example. One patient of ours, she refused to be included in the trial, and a couple of months later, she developed overt myeloma, and she started on a treatment which is the approved regimen, which was not the optimal regimen of today. And very soon she became relapsing and refractory. And today she's participating in a bispecific therapy. So what I have seen so far during this meeting, there is real myeloma among those patients, and it's a subgroup which can be recognized by sophisticated tools, which is not applicable to daily practice. And in the absence of such a technique, we have to evaluate these patients based on their behavior. I agree with Thanos that it should not be static. And Blade was the person who was mentioned about evolving smoldering myeloma for many years, and that is still valid for everyday life.
Excellent. Thank you. Thierry?
I agree with what has been said. As mentioned very nicely by Thanos, I think that I would basically favor the close follow-up for the majority of patients. I have to say that I am still a little bit skeptical about single-agent therapy for smoldering, and even so, I do believe that because there is a strong PFS benefit and some survival benefit, I think this will be likely approved, but not sure that approval is one thing, reimbursement is another thing, and I'm not sure that this study, at least the daratumumab study, will support reimbursement in all countries, and so. And then, you have always this debate which has not been closed on assuming that you have to treat a smoldering myeloma patient, would you prefer to give, let's say, the best possible myeloma treatment, or accepting to provide a single agent therapy, for example? This is still an open debate, but as nicely mentioned by Thanos also, this area of smoldering is very open to the discussion between the patient and the physicians, because the patient preference, you may discuss on patient preference in symptomatic myeloma, but it's even more important in smoldering, because what would you like to choose at the age of 40 years versus a gentleman at the age of 87 who will possibly receive safely a CD38 for a while, and maybe having the possibility of dying from something else. So it's very this is an area where patient preference matters a lot from my point of view.
Am I wrong saying that for patient, let's say above age 75, high-risk smoldering multiple myeloma, the group looks like doing a single agent daratumumab is not a bad idea, while the story is maybe different if you have a 55-year-old gentleman?
Yeah, I think we all agree with this.
Yeah, I would agree to say that. I would be more concerned and uncertain in treating a very young patient with a single agent.
Nizar, what's your take on this?
Well, at this meeting, there was two great presentations, one by Francesco Maura and one from Ahmed Samour from Farber. They studied the whole genome of smoldering versus myeloma. And strikingly, Ahmed Samour said something, I'll quote him word to word. He said the clone in smoldering myeloma is the exact clone you see in myeloma. And these were patients who clarified, these are patients who progressed from smoldering to myeloma. So I think really practically we should hopefully soon all agree to get rid of smoldering myeloma as an entity and define as transformed myeloma clone or plasma cell clone versus untransformed. That's how it should be. And the only equation left in this is to add the immune component, because as Francesco Maura also highlighted, although all these have the genomic signature of smoldering myeloma, they do progress eventually all to myeloma, but the timing varies. And the reason perhaps the timing varies is because the immune component, that's perhaps one component we have to add to the equation. So I hope in the future we'll just define my transformed plasma cell clone versus untransformed. And then the therapy, I'm not opposed to therapy, but I'm like I said before, I'm in favor of curative therapy. And the question, as we see now from the early bispecific antibody trials with Irene Gobriel and from this meeting with linvoseltamab with Paulo Rodriguez, responses are impressive. I mean, I have to admit, with linvoseltamab, small cohort, 6 patient with long follow-up, 80% complete remission rate. So what we're going to have to learn in the next few years, hopefully, that intervening early with a highly effective therapy, is it better than intervening late when the patient presents with organ damage or not? And that's what really the question I think we have to address. I think right now we should just start splitting transformed and untransformed, and the trial should look at intervening early with a highly effective therapy, whether it's even CAR-T. I would go far as that, if the CAR-T is safe, or the bispecific, does it cure that disease if you intervene early versus late?
Excellent. I feel that the topic is less confusing than what I thought, but there is some consensus among these experts, especially given the presence of the first author of the Aquila trial. So let's move now to the first line treatment of multiple myeloma. And again, the practical question to our audience is the role of transplant, because now, I mean, Susan started by mentioning Majestic 5 incorporating immunotherapies, bispecifics in the front line. But today, if we use the classical quadruplet, anti-CD38, bortezomib, len, dex, dara-VRd, isatuximab VRd, these are the ones available. Obviously, you can use carfilzomib instead of bortezomib. Should we offer transplant to the young and fit patient, or we can accept the idea that they don't go to transplant? What's your point?
My opinion
What's your
is very strong. Yes, I believe it's a mistake not to perform high dose therapy today. We have the Perseus data. I think it is premature to make decisions on early MRD negativity unless we see a very long follow-up. And I believe that all of us have experience with long-term disease-free survival patients, at least in our database, where we have a 15-year follow-up of patients that are without progression. 90% of these patients had received upfront high-dose therapy. So I don't agree with, I mean, storing stem cells for the future. I don't believe that you will cure anybody who will have a relapse. Of course, we have been impressed by CARTITUDE-1 data, but still, let's wait to see whether this is a true cure or not.
So, I mean, your answer is very clear, very strong, Thanos. The concept of deferred transplant is not valid for you. How is it for you, Susan?
So it's hypothetical. I mean, we don't have any availability of CAR T cells, for instance, upfront, but let's say we have a debate. Should we, if available, before we have data from CARTITUDE-5 and 6, should we use CAR T cells? It's a good question. I think the Perseus data, for me, they were shocking. This is 17-year progression-free survival. I mean, this is unheard of. This transplant. We have some, I would say, especially for younger patients, some safe tools. We have guidelines. There are some issues with CAR T cells upfront. I mean, the younger you are, the higher the risk of secondary malignancies. I mean, SPM, we discussed that with melphalan, etc. But we also have that New England Journal report with T-cell lymphoma, where you might have, a p53 positive T cell, and you put your lentiviral construct in it. This plays a role, toxicity, and then also we don't know whether the remissions are really longer. And so far, we don't have seen a final plateau in the CAR T cells, even early line of treatment. We are still losing patients. So I would say without a cure, I would like to see more data on CAR T cells before I switched out completely with transplant. So transplant is still on this. I always say, if I would have multiple myeloma, what would I do? I would take a quadruplet, I would take my bisphosphonates, I would take a transplant, maybe double maintenance. I have to check my MRD testing. hope for 17 years of progression-free survival, and then CAR T cells, which I think getting safer and safer.
This is
But
a
that-
very inspiring discussion. I love the clarity and avoiding the politically correct answers, guys. Well done. Because this is exactly what the audience is looking for. We are here to provide some practical answers to very hot, controversial topics. Nizar?
I agree with Thanos and Suzanne. I mean, we don't have the evidence about getting rid of transplant completely. But since we debate, I'll try to be controversial. I mean, if you look at the Cepheus data in patients who are 65 to 70, these patients are doing extremely well. And you can argue perhaps you need data VRD in everybody. And only if MRD is persistent at the end of your induction of 6 or 8 cycles, you can perhaps offer transplant or not. Even if
but
you look at
less well than similar patients who were transplanted on Perseus.
Well, I mean, that's what I'm saying. If you look at somebody with 65 to 70 Thanos, even on the Maya trial, I mean, and Thierry will speak to that. A 65 to 70 patient, I think the median PFS hasn't been reached yet on those patients, maybe just got reached. It's well beyond 70 months with DRD. So I think in the future, we need to look at the efficacy in subgroup of patient. Toxicity, as Suzanne mentioned, is going to be primordial. I think in an era of Hodgkin lymphoma and myeloma, where therapy is extremely effective, we have to look at the most effective and least toxic. But yeah, I agree. At this point of today, transplant is still part of the induction therapy for young patients.
So Thierry, Nizar threw the ball to you.
No, no, that's but you know when you look at Cepheus versus Perseus, there is still on one hand you have PFS 100 months, on the other hand you have PFS 200 months. So
And to be fair, with IMROS, we have the same results like Cepheus.
Age is not the same, etc. Of course, but you know. There is an impact of transplant, and I fully agree that transplant remains the standard of care in 2025. Just one additional comment. When that could be a nice and theoretical discussion. This is one thing. On the other hand, when you claim more and more that transplant could be delayed, transplant could be removed, you have to keep in mind that in many countries, in fact, transplant is extremely important because in many countries, there is no clear access to CAR T cell therapies. There is no access to bispecific. So you could say, in a certain extent, that it is a discussion between rich countries, and you know, the transplant is extremely cost effective. And if you look at the risk versus the benefits of transplant, it's definitely clear that we need transplant. We still need transplant today, and it will remain like this in many countries for a while, I would say, and until they may have access to something different, assuming that something different might be a little bit better. But I think it's when we say too much that transplant could be delayed or replaced, etc. This is a wrong signal for many countries. And okay, it's good to have a scientific and theoretical discussion on the need for transplant, but you have to go back to the real life and the routine practice in not only in the USA and other rich countries, but in many other countries.
Thank you, Thierry, for raising this, and I would like to commend the IMS leadership because there was actually a specific session dedicated to access to all of these novel therapies and cost issues in low and middle income countries. And this is a very complex debate. I'm not sure we'll be able to solve it today, but obviously we are all advocating for equal access, affordability, availability, accessibility, our AAA mantra at the ICH. Miral, what's your point of view?
So I just wanted to remind you that the MIDAS study will give us the results of this maybe the transplant versus non-transplant question, even the double transplant. So you should be the persons to give the answer to this question. That's what I wanted to highlight.
Well, although I think the conclusion of the MIDAS trial at this stage saying we have the readout with MRD, it is what it is, but I don't think the recommendation was to skip or avoid transplant. Although I must confess, when it comes to double transplant, I think the story is probably easier than for single transplant. And again, one argument that many people would use, and I remember Marie-V, Jesus San Miguel, saying, while we're talking about Perseus, a median of 200 months of PFS, Cepheus and Imrose, this is 100 months. So you have 100 months difference. Obviously, I'm not comparing maybe the same populations,
but
but
still,
it means that
but still.
melphalan is bringing a few months of PFS,
Yeah.
whether we like it or not.
Mm.
Excellent. Thank you so much, guys. We'll move now into the older patient. And I thought that in the older patient now, the debate is rejuvenated around frailty. I must confess, I was a bit disappointed because after the meeting and after being extremely disciplined and listening to everybody, I don't know how to assess frailty yet. Everybody is bringing his own scoring system, etc. So I'm still in favor of what Thierry published about, performance status and make it simple, shaking hands, maybe looking into the gut feeling or the clinical judgment. So is it fair to say that the backbone of treatment today for the older population is anti-CD38 Lendex? Everybody can receive this excellent safety profile in advanced ages. And the question is whether we can add a proteasome inhibitor to a few patients and we end up with Dara-VRd or Isa-VRd as in IMROSE, Meral?
So we participated in the IMROS study, and it was a really good study. And also we participated in the Cepheus study. These are the patients who are really fit patients, and we still see the infections and things which are related to the use of this quadruplet regimen. During this IMS meeting on the last day, I suppose, Andrew Lee presented a new protocol, which is daraxazumab plus LAN and dexamethasone with lower doses and more tolerable and with high efficacy. So and I think this is also a continuity of the Hovens trial earlier many years ago. Sonia Swigman had also presented a similar study combining ixazomib with daratumumab. So this type of approach may be also an option for those who are not able to tolerate the quadruplet in the full sense of VRd and decreasing the toxicity.
So you're advocating to bring back ixazomib because obviously its only approval is in the relapse setting, but obviously replacing bortezomib, oral drug, it has a gut toxicity, but you're right. It would be an option. Nizar, what's your take on this?
I mean, the result of this FAS and the IMROSE trials are quite impressive. And I heard from colleagues at the meeting, even in some small group site meetings, that why we should use the Dara-VRd, we should stick to Dara-RD. I think that would be a mistake because we've all been advocating for years that we need higher MRD rates. One of the shortcomings of the Maya, again, I'm humble to say that in front of Thierry, he's the leader on the study, the MRD rate is low. Only around 30% of the patient achieve MRD negativity. And that's what the Cepheus gave us and the IMROSE gave us, is high MRD negativity rate. So to say we're going to cut the Velcade out because they look same will be a mistake. Having said that, what you said, Mohammed, a frail patient, of course, we have to be very cautious and adapt the treatment on the patient need. So a patient who cannot walk, who have neuropathy, a patient who has issues with mobility, adding Velcade is inappropriate. So you have to adjust and drop the Velcade and default to the Maya in that case.
Susan?
Yeah, I just want to go back to the topic of frailty, and I think we overstimulated the topic a little bit. Myeloma doctor for, I would say, decades. I don't want to be disrespectful, but asking the patient to stand up and walk or asking why the patient suddenly has a wheelchair helps a lot. I think it's not realistic to sit down if you're a doctor, as old as me and see so many patients that you have a list and you make check marks, can you do vacuum? Can you do this? I think it's important, but I think we should somehow say it's enough, we don't need another score, to be very honest, that's my impression. And on the other hand, as much as I love the Maya trial, and I think it was so important, it was really groundbreaking, and especially for the first time, it brought more aggressive treatment to the older patients. I have a little problem with the Maya trial because the 25 milligrams of len are rarely given. It's a lot. And I think the IMROS data and benefit data for the first time allow us to give a quadruplet, but adjust the dosage, give a lower dose of Velcade, dose reduce the lenalidomide, and have even more or same efficacy. And patients tolerate that very well. Ixazomib, I would only give it if patients have neuropathy problems. So Ixa has a little better profile in terms of that. But otherwise, usually, I mean, ISA VRD, DARA VRD, and reduced dosage for older patients, why not? I'm not talking about 95-year-old patients. I just want to make sure, that the real frail ones.
Can I ask something to all of you? If you have a 90-year-old patient, would you prefer to give him on top of daratumumab a touch of bortezomib every week and titrate, or to put him on lenalidomide?
Well, I can answer this, Thanos. I had half a dozen of patients above age 90, between 90 and 95, where we have delivered Dara-Lendex very nicely, very safely. Obviously, if they have reached age 90 and 95, they are quite fit in general with their myeloma. And the trick is about, at least in my practice, is about adjusting len. I never start, we went even to 10 milligram, but also adjusting dex. Just give a small dose of dex. And DARA doesn't represent any problem at any advanced age, but maybe people have other experiences. Thierry, what do you think?
I think that it's an interesting debate. On one hand, you have this core discussion. So you may discuss for hours and hours about frailty scales, frailty scores, and nothing is perfect. And some of them are very simple, some of them are not simple at all, etc. And so this is one thing. Then when we are what we are talking about is, let's say we're talking about Daralen without, you could say, without dex or few dex, like in the IFM study. You could say this is Daralen, or this is a classical DRD. This is a quad. And then you could say some patients some on the top of this, some patients will get transplant. Then here and when you are talking about these three or four things, you are basically talking about frailty. Because what you have in mind is that the very frail, or you will have your personal frailty assessment, and you will say this particular gentleman will receive daratumumab and lenalidomide. This other gentleman will be able to get 4 drugs. And on the top of this, you could say that some of them will proceed to transplant. And then in this discussion, for example, you have in interesting parts. So some good colleagues, they basically say that if you are quad eligible, it means that you are transplant eligible, or the majority of these patients are in fact transplant eligible. But for some of them, you will prefer to defer transplant, or not to proceed to transplant. But this landscape is basically a frailty. Is inside all these regimens, you have a frailty discussion or a frailty assessment. So this is important, and this is the reason why many years ago, at the time Antonio Palumbo published the IMWG frailty score. uh, in 2015, this was not useful, because in 2015, at the time of, you had a few new regimens, and all elderly patients were able to receive MPT, MPV, MP, or whatever, something like that. But as of today, at the time you have Daralen only versus quad regimens versus Perseus-like regimens, possibly having carfilzomib for some patients. And then you could say the best is yet to come, or the more complicated things are yet to come. One day you will discuss CAR-T in frontline or bispecific in frontline, at this stage, the need for some kind of frailty assessment is extremely strong. And in fact, it is part of the discussion you have.
But I think, Thierry, just a word in defense of Susan. She was
No,
denying, I think, the issue of frailty. And I agree with her. It's about maybe as a practicing clinician, we can rely on clinical judgment and common sense, and we
I
don't need
always
3 pages of questions and answers.
I always agree with Susan, and this is exactly I agree with Susan. This is the reason why we should keep the frailty score discussion as a special discussion, let's say. And one day we may have a better score, but it's likely that
It could
nothing
be
will be
useful for
perfect.
prospective trials to
But you do,
compare across trials.
Susan says, I'm not doing using frailty score, but Susan is doing frailty assessment, and we are all doing frailty assessment. At the time we say, this elderly lady is able, I do believe that she is able to tolerate and she is able to receive isatuximab or daratumab vedotin. In doing that, you do a frailty assessment. That could be few seconds, or
I
that could be,
think you
but
can
you
decide
do it.
when you see the patient walking into
Exactly.
your
So
office.
basically, you do it. In fact,
Like we do it with ECOG or Karnofsky. I mean, this is all a clinical evaluation. We don't have 10 questions, to answer in order to see.
This is the rationale for okay, I will not be too long, but at the time we published this the so-called IFM simplified frailty score, which is which got a lot of criticism anyway. We had only age and comorbidity. So at the time you see your patient, age and comorbidities and ECOG. ECOG is basically what Suzanne is doing. She looks at the patient and she say, okay, this is ECOG 0 or 1 or 2, and you need 3 seconds to do ECOG. Basically, you look at what we have done before, and you look at your patient that particular day. So this is very simple, and I suspect that basically what we call IFM simplified frailty score is some kind of very is close to the usual frailty assessment we do every time, in fact.
Excellent. Thank you all for your contribution to this exciting debate. But at the end of the day, I think it's good news because the outcome of patient, irrespective of any score you're using, is improving. And that's exactly the goal. Let me move now to another very hot topic, and which is highly debated, is the management of first relapse. And I think it is still true today, even in 2025, that when we combine the first line treatment and then the first relapse treatment, probably we're talking about more than 80 or even 90% of the survival of a myeloma patient. So at some point, we should not miss this management of first relapse. And my question here, and just to set the stage, let's assume that CAR T cells like cilta-cel is available for management of first relapse. And this is, of course, based on the results of the CARTITUDE-4 trial. Let's assume that belantamab combined with bortezomib or with pomalidomide is also available. This is the DREAM7, DREAM8 trial. And let's assume that we do have bispecifics available for early relapse, because they will come. Obviously, the label is not yet there, but I think we can have a reasonable discussion, scientific discussion. And I would assume that this is a 65-year-old gentleman who is relapsing 10 years after transplant, receiving VRd, melphalan, len maintenance. This is the majority of the patient you would face today. And the patient actually can receive all of these options. So please don't debate the issue if he has like his heart failure or whatever. And this patient really trusts you. So what are the factors you would use to choose the most appropriate therapy for this patient. And you may be able to use everything, Susan.
Yeah, I start because I have to leave, right after. Probably CAR T cells, 65 years CAR T cells. Best, we have data, on the first relapse, long progression-free survival, overall survival. And so far, we only have the BCMA CAR T cells available. So then I could have the option, if the case there's early relapse, switch to talquetamab, for instance. That would be my approach, that I have a good option, after the CAR T cells for now.
Okay, so you are in favor of CAR T cells if they are available, and you would definitely go to CAR T cells first relapse. Nizar.
I agree with Susan, but I'm curious to see the result of Majestic-3 and Magnetism-5. So DARA bispecific early in a patient like this who's not DARA refractory. And the only reason I'm interested in that because of the toxicity of CAR T that Suzanne mentioned earlier. We're still concerned about secondary malignancies, T-cell lymphomas, and so forth. So if these studies read out with an equal PFS and equal depth of response, I'll be tempted to perhaps consider bispecific in a patient with much lower toxicity with bispecific antibody, especially if we adopt limited duration of treatment.
Excellent. Merad.
So I think I would consider the CAR T cell if the patient has relapsed early. But if the duration of the first remission was like 5 years, 3 years, I would reconsider giving a second transplant. Although people have forgotten this, because I think many societies are spoiled by the multiple options that they have. But in countries such as mine, stem cell transplant is still a major option. And regarding early relapse and aggressive disease, it is also possible to predict ahead of time. Maybe people are following, we published with an EBMT early relapse score. This is also predictable before the transplant to see which patients will relapse early. And those could be candidates for CAR T early on. I favor giving one therapy instead of giving long treatment periods.
Excellent. Thanos, a word in defense of antibody drug conjugate. You've pioneered
Well,
some of these studies with belantamab.
that if the patient, if the patient has such a long remission, and I repeat the cytogenetics, and he still does not have any high-risk cytogenetics, I would not consider CAR T cells. I would consider any of the options that can give you a median PFS of 36 months. And I could even consider, after a short induction, a second transplant if the patient, is willing to go through the same procedure. I think definitely, for shorter remissions, high progressive disease with, bad features, adverse cytogenetics, definitely CAR T cells, specifics, whatever is available.
Okay, Thierry.
No, I agree. For your particular patients having received, I do not remember if it was VRD or CD38 VRD and transplant.
No, VRD. VRD.
Okay. So for your patient did not receive a CD38. So you have a VRD LAN, transplant LAN, and 10 years. So for this particular patient, I will not be using CAR T cell, to be honest, but because it's unless this relapse is extremely aggressive or something like that. But I would likely not favor CAR T cell in this particular case. Then
So you would go, Thierry, for an anti-CD38 plus carfilzomib like Ikema or
I
Kendo?
would go for an anti-CD38 based therapy. I would say. But I think,
But if you combine daratumumab with Pomdex or isatuximab with Pomdex, I know this is not first relapse, but the median PFS was rather 11 months.
No, but this particular patient, I would never go for CAR T cell therapy without any exposure to CD38 from my point of view. But let's say it like this. Then, as said by Thanos, the more you have an aggressive myeloma, the more you have poor biological characteristics or whatever, the more CAR T-cell therapy is attractive, I would say, because in this case, you can balance the risk and the benefit, and you can say that the risk of SPM, the risk of atypical neurological toxicity, for example, can be more acceptable in patients you feel with a poor clinical outcome with conventional therapy. So because of course we would like to see a very long follow-up of, let's say, the CARTITUDE-4 study, for example. The study says that the neurological toxicity seems to be limited, SPM seems to be limited so far, but in fact we do not know really. And so if you expose to CAR T-cell therapy a patient at the age of 45 years, and if you get either SPM or Parkinsonism or whatever, I think you will have probably the feeling that you did not do a very good job. So I think it's good to have access to CAR T-cell for first relapse, but for sure, not all patients will get CAR T-cell at the time of the first relapse, and that's still a difficult discussion. I think the first step would be CAR T-cell or not, and if not, you get the next discussion would be ADC versus bispecific, for example. But it's definitely not a simple discussion. And you propose a case study, but you may put 5 different case stories, for example, asking the same question, and our answers will be likely different, in fact, according to patient characteristics, so the time of relapse, characteristics of the relapse, etc.
Meral, you wanted to add something about this?
Yeah, I wanted to mention that there are two issues. One is related to the CAR T persistence, and during the IMS meeting, there were many abstracts and speeches about using either cell modes or IMiDs, and also even bispecific cemiplimab was also presented, which is changing the target from BCMA to FcRH. And so there is still some improvement needed. It's because these are patients who are relapsing later on. But if we could reserve CAR T early on to have the best outcome, that would save a lot of cost effectiveness. And regarding the ADC, during the IMS meeting, for me, it was the first time I heard about the naked belamaf. And so the molecular antibody without the payload did not produce any ocular toxicity. And this by itself had a good overall response rate, which can be improved by a combination. Now, when it was asked to the presenter, what is the ideal partner for this naked antibody? And she replied that the ideal would be to have the ADC, belantamab. So this is a new topic worth discussing in future.
Okay, wonderful. I think I'll move on now to the last question, last chapter in our discussion. And this is actually connected to the use of CAR T cells, but also bispecific and antibody drug conjugate, which is the management of ultra high risk myeloma patient, whether frontline or whether at time of first relapse. And especially that more and more we're speaking about a sort of a dynamic high risk assessment, especially in those early relapses. So my simple question, the answer may not be very simple, is what is your recipe today to manage these ultra high risk patients? Nizar, tomorrow you have such patient. What do you propose? We need your microphone.
Thank you. As you mentioned, definition of ultra high risk is also in dynamic movement, because what may have been a high risk or double high risk myeloma, as we find even recently by the JCO publication before immunotherapy, may not be the same. For example, in the future, I don't think that 17p deletion by itself, even in a double hit setting, would be a high risk. likely CDKN2C, 1p32 loss, and 1q gain will remain a high-risk immunotherapy. Disease bulk will become a major factor in immunotherapy once we introduce immunotherapy early. But nevertheless, today, if I have a patient who's very high disease burden, very aggressive disease, I think it's important before we introduce immunotherapy try to debulk him, whether, as we saw from the presentation from Dr. Binod with talquetamab as a bispecific antibody debulking therapy followed by CAR-T, or whether you do that with old-fashioned chemotherapy as well, to even DICEP to try to debulk him and then proceed to some form of immunotherapy. But today, I agree that the best treatment approach for a high-risk patient is introducing whether CAR-T cells or bispecific antibody to this patient.
Meral, do you agree? How do you manage today in your center a high-risk cytogenetics, ultra-high-risk patient who's fit and who's age 60?
So for those, I can use their VRD for frontline, and then this is the only option, that condition that we try to use tandem transplant. And of course, if the patient is eligible at the next step, becomes still with M protein, then we can include in clinical trials. And we are looking forward to the tri-specific trial to be launched soon. And the tri-specific data presented at the IMS meeting were very impressive, including patients with extramedullary disease and also high-risk disease. So I think for those type of patients, using dual antigen targeting seems to overcome some issues, maybe not completely, but it's a major improvement.
Okay. Thanos, are you still considering double transplant for these ultra-high-risk patients?
Well, I believe that at this point, with quadruples and the availability of CAR-T cells and bispecifics, I would not. I agree with Nizar that these are the patients, that we need to be to treat them early, and even consider adding radiotherapy to areas of bulky disease, because we know that part of failure of CAR-T cells in solid tumors is, the hostile microenvironment created by bulky tumors.
Okay, Thierry?
Yeah, I think if you ask the question for today, I think today we have what we have. We have, let's say, this particular patient in your country may receive a kind of MIDAS schedule, let's say, cetuximab KRD or daratumab KRD, whatever. Then I expect that some improvement will be obtained with as we said, with either bispecific, tri-specific, CAR-T cell therapy. And back to this, when you look, for example, at the Majestic 5, combining for induction TEC-LEN or TEC-VR or whatever, and you end up with, let's say, almost 100% of patients MRD negative after a few cycles, you can imagine that at least some high-risk patients will benefit from this. So it seems to be clear that the bispecific, tri-specific, and CAR-T will for sure improve the outcome of high-risk patients. So as soon as we can implement these strategies.
Excellent. As we come to the end of this ICH webinar dedicated to the highlights of the IMS meeting in Toronto, let me thank you for your active participation and engagement. I think the past week has clearly demonstrated how rapidly the field of myeloma is evolving. We're witnessing a true paradigm shift from early intervention strategies in high-risk smoldering multiple myeloma to increasingly personalized frontline therapy guided by frailty, but also, of course, the emergence of novel platforms such as CAR-T cells, trispecifics, bispecific, but also antibody-drug conjugate, as we've discussed in first relapse. But I think at the same time, we are reminded of the challenges that remain, particularly in ultra high-risk refractory disease. This is what we just discussed at the end. And of course, our collective responsibility is to transform these promising scientific advances into real improvements in patient outcome worldwide. And I'd like to emphasize the issue of accessibility and affordability. I think the discussions today have underlined not only the progress made, but also the importance of collaboration, education, but also critical debate, which is at the heart of the ICH mission, our mantra, Hematology Without Borders. On behalf of the ICH, I thank our distinguished panelists for their excellent insights and all of you for joining us. And we look forward to continuing this journey together and to seeing you at our upcoming activities and meeting. Thank you.
Thank you
And
very
until
much.
next
Thank you for
time,
the
take care.
Thank you
invitation,
very much. Thank
Mohammed.
you. Bye-bye.